Okay, let's unpack this. Imagine a hidden threat, a subtle shift within your body that, if left unnoticed, well, it can devastate health and shorten life. That's the challenge we're tackling today on the deep dive. Our mission, as always, is to give you a shortcut to being truly well informed, extracting the most important nuggets of knowledge and insight. We're taking a deep, deep dive into a condition that's as complex as it is critical: pulmonary hypertension.
Indeed. Pulmonary hypertension, or PH, it's a prime example of a disease where early, accurate understanding and precise intervention can make all the difference. Today, we're going beyond the basics, really equipping you with the kind of comprehensive understanding that truly sets elite professionals apart in this field. We'll be drawing extensively from Chapter 283 of Harrison's Principles of Internal Medicine, a foundational text, to dissect every facet of this condition and really help you master the material.
Yeah, mastery is the goal here. So, whether you're prepping for a critical meeting, catching up on a vital medical field, or you just possess an insatiable curiosity, get ready for some serious aha moments. We're going to break down not just the definitions, but the intricate what's going wrong at the cellular and molecular level, how we rigorously diagnose it, and of course, the cutting-edge treatments that are transforming lives. You'll walk away with a truly masterful grasp of pulmonary hypertension, understanding those nuances that distinguish the top-tier professionals. So let's start with the absolute fundamentals for our listener. What is pulmonary hypertension at its very core? And why is really nailing this foundation so vital?
Right. At its core, PH is a remarkably heterogeneous disease. And what that means is it's not a single thing, but rather a collection of conditions. They're all characterized by this pathogenic remodeling of the pulmonary vasculature. So this remodeling, it's a structural change in the lungs' blood vessels, and it leads to two critical issues. First, you get a progressive increase in pulmonary artery pressure. And second, a corresponding rise in vascular resistance. So think of it like the pipes in the lungs getting narrower, stiffer, less flexible, making it harder and harder for the heart to pump blood through them.
And why is it so important to grasp that right away, this whole idea of remodeling and its consequences?
Because this foundational understanding, it informs absolutely everything else we'll talk about. If we connect this to the bigger picture, it explains why the symptoms are often so nonspecific and why pH can be so insidious, creeping up slowly. The body, it's remarkably adaptive, right? It tries to compensate for these increased pressures and resistance. It's often this slow, silent progression where the right side of the heart just works harder and harder to push blood, kind of masking the underlying issue until it becomes pretty severe. And that compensation mechanism, that's precisely why we often see these significant delays in diagnosis and why, as elite professionals aiming for mastery, we have to maintain a really high index of suspicion.
You mentioned heterogeneous, which, like you said, implies it's not just one thing. Could you elaborate on that? Especially the crucial distinction between PH as this big umbrella term and pulmonary arterial hypertension, or PAH.
Absolutely. That's a key point. PH is indeed the broad umbrella term for any condition involving elevated pressure in the pulmonary arteries. However, pulmonary arterial hypertension, PAH, that's a distinct, much more uncommon, and particularly severe subtype. We often focus on it because it has a unique pathology and, importantly, specific treatments. PAH is characterized by this complex interplay of molecular and genetic events that cause what we call an obliterative arteriopathy.
Obliterative arteriopathy.
Okay. Yeah. Picture the smallest blood vessels in the lungs, the arterioles becoming narrowed, stiffened, and sometimes even completely blocked, obliterated due to abnormal cell growth, inflammation, remodeling of their walls. It's not just simple constriction. It's a fundamental structural change. And this specific, progressive, severe remodeling leads to those characteristic symptoms like dyspnea, shortness of breath, chest pain, and syncope or fainting, especially when someone exerts themselves.
And the stakes are incredibly high if it's PAH, particularly as it gets more advanced, aren't they? What are the grim realities of this specific subtype?
You're absolutely right. The stakes are profoundly high. If left untreated, PH, and especially the PAH subtype, carries a very, very high mortality rate. This grim prognosis is largely due to decompensated right heart failure. We'll definitely circle back to this later. It's critical. But just to elaborate briefly, the right side of your heart, it's built to pump blood through the low-pressure lung circulation. When those vessels get stiff and highly resistant due to PAH, the right ventricle has to work against enormous pressure. Over time, it just struggles. It gets thicker, then it stretches out, and eventually it fails. It just can't adequately pump blood anymore.
Wow.
And that leads to congestion, fluid retention, and ultimately this catastrophic decline in cardiac output, which, sadly, can be fatal.
Mhm.
It really hammers home why early, accurate diagnosis and aggressive treatment are just paramount.
Now, this next point is truly fascinating for anyone in the field, for anyone trying to master this. A fundamental change in how we even define pH itself has occurred recently. Could you walk us through that shift and its pretty profound implications?
Yes, this is indeed a game changer, a really significant advance in how we approach this condition. The diagnostic mean pulmonary artery pressure, the mPAP threshold, it's been lowered. It used to be 25 millimole Hg, now is 20 millimole Hg.
Okay, so from 25 down to 20.
Exactly. And this isn't just, tweaking a number. It represents a real paradigm shift towards earlier detection and intervention. Historically, waiting for that higher pressure meant that by the time pH was diagnosed, the disease was often more advanced, right? With established, sometimes irreversible vascular damage. The new lower threshold lets us identify patients much earlier in the disease spectrum.
Why was that change so necessary? What was the sort of clinical thinking behind it?
Well, the clinical imperative was driven by really compelling evidence showing substantial diagnostic delays.
Oh.
Clinical registries consistently show that delays, often averaging up to 2 years, are common.
2 years, wow.
Yeah, and that delay has profound, devastating implications for both a patient's quality of life and, crucially, their lifespan. So by lowering the threshold, we're proactively encouraging clinicians to recognize subtle signs earlier, to start a systematic evaluation in patients who might be at risk, and to complete that workup sooner. This whole proactive approach, it ultimately leads to prompt diagnosis, allows us to start appropriate treatment earlier in the disease course, and optimizes outcomes by intervening before the disease has progressed too far and caused, irreversible damage.
So if I'm hearing you right, it's not just about changing a number or a label. It's a fundamental shift in clinical philosophy, really giving patients a fighting chance earlier on.
Precisely. That's exactly it. This redefinition is a powerful example of how knowledge, when it's refined and applied, directly translates into saving and improving lives. It fosters greater vigilance, encourages a lower threshold for suspicion, and empowers clinicians to act decisively, potentially intercepting the disease at a stage where therapies can have a much, much greater impact.
Yeah.
It's an insight that really separates an informed practitioner from one, operating with outdated parameters. It's key to mastery.
Okay. Understanding what pH is at its core leads us right to the next critical question. How does it actually happen at the microscopic cellular level? Let's dive deeper into the cellular crime scene, as you put it earlier. What's happening down there to cause this devastating obliterative arteriopathy in PAH?
Right, the pathogenesis of PAH, it really is like a complex cellular crime scene. It's rooted in several profound abnormalities involving specific cell types within the pulmonary vasculature, mainly the endothelial cells lining the vessels, the smooth muscle cells on the walls, and the adventitial fibroblasts, the support cells. At the heart of it, we see these key cellular dysfunctions. Things like apoptosis resistance, where cells that should die off don't, uncontrolled cell proliferation, so cells grow excessively, dysregulated metabolism, their energy processes go haywire, often resembling cancer cells, actually.
Really? Like cancer cells?
Yeah, favoring anaerobic glycolysis, and increased oxidant stress, which causes cellular damage. So all these events, they culminate in this dramatic remodeling of the distal pulmonary arterioles, those tiny vessels way out in the lungs. Imagine them getting structurally altered and stiff. Specifically, we see decreased vascular compliance. They get rigid, can't expand and contract properly, and crucially, there's a heightened propensity for in situ thrombosis.
Meaning clots forming right there?
Yeah, exactly. Blood clots forming directly within these small remodeled vessels, further blocking blood flow and making things worse. To visualize it, think of the contrast. A healthy pulmonary artery, smooth, open channel, but one with severe PAH. The walls are thick, almost muscularized from overgrown smooth muscle. The inner lining, the intima, is scarred and fibrous, and in really severe cases, the whole lumen, the opening, can be choked off by collagens and debris, just blocking flow. It's not just narrowing, it's a fundamental destructive transformation.
So it's not just about narrowing the vessel, like you said, but a fundamental, really destructive change in the wall itself, making it rigid and clot-prone. And you mentioned heterogeneity even within PAH. What's this vasoconstriction dominant phenotype you mentioned?
Ah, yes. That's a perceptive point. While that structural remodeling is the hallmark, it's important to recognize that a minority of patients seem to exhibit this vasoconstriction dominant phenotype. In these folks, the primary issue, at least initially, seems to be excessive constriction or spasm of the pulmonary vessels, often with maybe less severe or earlier structural remodeling. This distinction is critically important because if a patient mainly has this constriction component, They often respond remarkably well to specific vasodilatory therapies, drugs that relax the vessels.
Ah, good.
It allows for a unique and often highly effective treatment strategy. It's a subset that, when we identify them, offers a particularly favorable prognosis, which really emphasizes the need for thorough diagnostic testing, including vasoreactivity testing, which we'll definitely get into.
You talked about molecular and genetic events playing a role. Can you tell us more about the specific abnormalities researchers have pinpointed, the sort of molecular signatures of PAH?
This is truly where the science gets exciting, and where our understanding, essential for mastery, is rapidly advancing. Researchers have pinpointed abnormalities in multiple molecular pathways and genes that regulate how those pulmonary, vascular, endothelial, and smooth muscle cells function. We're talking about crucial players like decreased expression of voltage-regulated potassium channels that affect cell excitability. Then there are well-known mutations in the bone morphogenetic protein receptor 2, the BMPR2 gene, that's a key regulator of cell growth and a strong genetic link to PAH.
BMPR2, right? I've heard of that one.
Exactly. Also increased tissue factor expression, which promotes clotting locally, overactivation of the serotonin transporter, influencing vessel tone and cell growth, and hypoxia-induced activation of HIF1 that's linked to oxygen sensing and cell proliferation. And there's more, like activation of NFA, pointing towards immune system involvement and inflammation.
Wow, that's an incredibly intricate network of specific pathways and genes. It sounds almost like a completely different disease process than what you might initially imagine for just, a blood vessel condition.
It is. And this intricacy leads to some profoundly insightful connections. If we connect this to the bigger picture, a particularly intriguing recent discovery and a real aha moment for the field is the significant overlap in PAH pathobiology with solid tumor cancers.
Cancers, really?
Yes, this isn't just a curious parallel. It fundamentally redefines how we conceptualize PAH, not just as a vascular disease, but potentially as a proliferative disorder with characteristics similar to neoplasia, to cancer. This insight has led to identifying proteins like pyruvate dehydrogenase kinase and NEDD9 as important players in PAH. Both are also heavily implicated in cancer growth and metabolism.
That's incredible.
It is, and this connection is already pushing us towards rethinking therapeutic targets, maybe even considering existing oncology drugs, perhaps modified. It's a truly paradigm-shifting avenue for research and future therapies. Absolutely critical knowledge for anyone serious about this field.
That's a truly surprising and powerful connection. And thrombin, the enzyme central to blood clotting you mentioned, that plays a role too in this complex web.
Yes, absolutely. Thrombin deposition in the pulmonary vasculature is another critical piece of this puzzle. Whether it's an independent abnormality in some patients or just a downstream result of the initial endothelial dysfunction, thrombin can significantly further amplify this obliterative arteriopathy. As a key enzyme in clotting, its presence contributes directly to the fibrotic and thrombotic changes that progressively block and remodel those arterioles. It acts like a relentless destructive force, adding fuel to the fire.
So these intricate cellular and molecular changes, what do they lead to on a larger scale within the body? How does the body try to cope with this rising resistance, and what are the ultimate systemic consequences of that struggle?
Right, so on a larger scale, these profound pathologic changes result in a progressive, relentless increase in total pulmonary vascular resistance, or PVR. As PVR climbs, the mean pulmonary artery pressure, mPAP, also dramatically increases. Now, to maintain adequate cardiac output, to keep enough blood flowing to the body against this huge increase in right ventricular afterload, the right ventricle just has to work much, much harder. It's trying desperately to push blood through these increasingly resistant, stiffened vessels.
And that extra work just isn't sustainable, is it? The heart can only compensate for so long.
No, it's not sustainable at all. And this is where the disease becomes truly devastating. A sustained, excessive increase in right ventricular work causes this critical shift in its systolic function efficiency. What that means is, while the right ventricle tries to maintain pressure, it does so at a tremendous metabolic cost. It starts burning through energy reserves needed for optimal blood flow. This leads to a critical condition called pulmonary arterial uncoupling. Basically, the right ventricle can no longer effectively pump blood into the stiff, high-pressure pulmonary arteries. Yeah, it's like trying to pump water through a hose that's progressively kinking eventually. The pump itself just starts to burn out and fail. This uncoupling signifies a profound shift. The right ventricle isn't effectively partnering with the pulmonary circulation anymore. It's not just working harder, It's working inefficiently, burning out, heading towards failure.
So it's not just the lungs suffering, but the very engine pushing blood to them, the heart, is being critically damaged. This sounds like a systemic catastrophe unfolding.
Precisely. And in end-stage PAH, the cardiac output drops dramatically. Ironically, this can sometimes lead to a decrease in mPAP simply because the failing heart can't generate enough pressure anymore. But the impact goes far beyond just the heart and lungs. As you see in illustrative diagrams, this disease triggers widespread systemic responses. We see overactivation of neurohumoral signaling, increases in hormones like angiotensin II, aldosterone, even bioactive estrogens. These contribute to fluid retention and more cardiovascular stress. We also frequently see chronic kidney disease developing and volitional muscle atrophy, skeletal muscles wasting away, likely due to deconditioning, inflammation, the whole systemic hit. And the right ventricle itself. It undergoes profound changes. Dysfunction, hypertrophy, it thickens, then fibrosis, scarring, and then dilation, it stretches out, all contributing to a dramatic decrease in that RVPA coupling, meaning the right ventricle and pulmonary artery are just completely out of sync.
Wow.
It really drives home that PH isn't just a localized lung problem. It's a systemic challenge for the entire body, a truly humbling and devastating disease to manage.
Given how serious and devastating this condition is, you'd think it would be relatively easy to spot. Yet the sources tell us time and again that it's often missed, sometimes for years. What makes early diagnosis such a huge challenge?
Yeah, it's a truly significant shortcoming in clinical practice and unfortunately a common reality. Clinical registries consistently show PH is frequently overlooked, even in patients with numerous clear risk factors. The reasons for this profound diagnostic delay are, well, multifaceted. First, PH symptoms are notoriously nonspecific, right? Shortness of breath, fatigue could be a million things.
Right.
They're also insidious. They develop slowly, subtly. Patients and clinicians might just dismiss them as, getting older, being out of shape, maybe mild asthma. And critically, these symptoms overlap considerably with many far more common conditions like asthma, COPD, left heart failure. There's also this pervasive misconception, unfortunately, that if a patient already has another cardiopulmonary condition, PH is just an extension of that disease, rather than a distinct entity needing its own diagnosis and management. This overall lack of a reasonable index of suspicion, as the texts say, is a major ongoing barrier.
So it truly is a master of disguise hiding in plain sight. Given that, what are the key signs and symptoms that should raise a clinician's suspicion? What should prompt that deeper look, moving beyond those initial vague complaints?
Okay, so the initial presentation for most patients will be that dyspnea, shortness of breath, especially with activity and/or fatigue. Those are the red flags that are easily missed. Less common, and typically meaning more advanced disease, are symptoms like edema swelling, often in the legs, chest pain, presyncope, feeling like you might faint, and syncope, actually fainting. That last one, syncope, is particularly worrying as it often indicates a significant hit to cardiac output. And in the very early stages of PAH, the physical exam is often, frankly, unrevealing, which just contributes further to the delay. A doctor might not find anything obviously wrong just by listening or examining the patient initially.
But as the disease progresses and the right heart starts to struggle more severely, do the physical signs become more evident, more specific?
Yes, absolutely. As the disease advances, you'll start to see clear, often palpable evidence of right ventricular failure. Things like elevated jugular venous pressure in the neck, reflecting that high pressure in the right heart. Lower extremity edema, swelling in the legs from fluid backup, and ascites fluid in the abdomen. The cardiovascular exam itself can reveal more specific findings too. An accentuated P2 component of the second heart sound that loud snaps, signaling high pulmonary pressure. A right-sided S3 or S4 heart sound, abnormal sounds indicating ventricular problems. And a holosystolic tricuspid regurgitant murmur blood leaking backward through the tricuspid valve due to the pressure in the right ventricle stretching.
Okay, so more distinct clues emerge later on.
Exactly. And additionally, it's crucial to actively look for signs of commonly concurrent diseases, which can sometimes hint at the underlying cause of the PH. For instance, finger clubbing in chronic lung diseases, or sclerodactyly tight skin on fingers in telangiectasias, those spider veins hinting at scleroderma. Even crackles on lung exam or systemic hypertension could be clues pointing towards left-sided heart failure as the driver.
Once suspicion is raised, what's the systematic approach? Walk us through the step-by-step clinical evaluation that an elite professional, someone aiming for mastery, would undertake.
Right. Once suspicion is sufficiently high, a systematic approach is critical. Think of it like a diagnostic flowchart. It begins with initial screenings, An electrocardiogram, ECG, might show signs of right ventricular hypertrophy or strain and advanced disease patterns like right axis deviation, prominent R waves in V1, but an ECG alone isn't definitive. Chest X-ray, or röntgenography, can reveal enlargement of the central pulmonary arteries, which are trying to cope with the pressure, and maybe obliteration of the retrosternal space if the right ventricle is enlarged. Again, suggestive, but not conclusive.
And echocardiography, the ultrasound of the heart, that plays a significant role here, doesn't it?
Yes, echocardiography, especially if done with an agitated saline or bubble study to look for holes between heart chambers, is often the most important initial screening test. It can non-invasively estimate the pulmonary artery systolic pressure, typically flagging anything over 35 mmHg as suspicious, and it can directly visualize a hypertrophied or dilated right ventricle, which strongly supports a pH diagnosis. Echo also gives vital info about potential causes, like valve disease or left ventricular problems, crucial for differentiating pH subtypes. However, and here's a critical nuance for the learner to grasp, absolutely key for mastery, a truly normal, high-quality echo, where everything looks perfect, might mean further pH evaluation isn't needed. But this is very different from an echo where, say, tricuspid regurgitation isn't detected well, or the views are suboptimal. In that case, you're missing the data needed to accurately estimate the pressure, and pH can still be present in up to a third of those patients.
Wow, okay. So an unremarkable echo doesn't necessarily rule it out if the data isn't complete?
Exactly. An unremarkable echo, especially with poor views or no TR jet, combined with unexplained shortness of breath, often still requires further assessment. You cannot just dismiss pH based on an incomplete echo.
That's an absolutely crucial detail for practice. Beyond imaging, how do we assess functional capacity, the actual burden of the disease on the patient?
Right. Quantifying the burden and tracking response is key. We use tests like the 6-minute walk distance, 6 mWd. It's simple. How far can the patient walk in 6 minutes? Gives a practical measure of exercise tolerance. Cardiopulmonary exercise testing, or CPET, is also invaluable. This is a more sophisticated test. It helps differentiate between heart versus lung causes of shortness of breath and gives an objective measure of peak oxygen consumption, VO2 peak, a great integrated measure of fitness. Typically, a truly normal CP means further invasive testing for pH isn't needed. But another important exception in highly conditioned individuals, elite athletes, right? Their baseline is sky high. So a CP result that looks normal for the average person might still represent a significant, concerning decline from their personal baseline.
Ah, okay. Context matters.
Exactly. For those individuals, further assessment might still be warranted if their symptoms are new and unexplained, even with a normal CP at number.
Once pH is suspected, what about specialized diagnostic tests to really narrow down the cause and identify specific subtypes, nail down that diagnosis?
This is where we go deeper. Pulmonary function testing, PFTs, can give clues suggest restrictive or obstructive lung diseases as the underlying cause. In TH specifically, a classic finding is an isolated reduction in the diffusing capacity for carbon monoxide, DLCO, even if other lung volumes look okay. Reflects damage to the lung capillaries. High-resolution CT, HRCT, of the chest gives crucial anatomy. Shows pulmonary artery and RV enlargement, yes, but importantly, it can pick up subtle signs of pulmonary venous congestion like ground glass changes, thickened septa. If there's no left heart disease, that might point towards pulmonary veno-occlusive disease, a rare but severe cause. HRCT is also essential to spot underlying interstitial lung disease or emphysema. Sleep studies are also key. Low oxygen at night, nocturnal desaturation is surprisingly common in PH, even without classic sleep apnea symptoms like snoring. So all patients with suspected PH should get nocturnal oximetry screening, regardless of sleep apnea symptoms.
Okay, comprehensive approach. And for patients with a history of blood clots, how do we specifically look for chronic thromboembolic pulmonary hypertension, CTEP-8?
Right, for anyone with a history of pulmonary embolism, assessing for CTEP is absolutely vital. CTEP is that specific, often curable subtype caused by old, organized clots blocking the pulmonary arteries. It's notoriously underdiagnosed. Ventilation perfusion, VQ scanning is the primary screening test. A normal VQ scan pretty much rules out CTEP.
Okay, VQ scan first.
Yes. If the VQ is positive, then CT angiography helps stage the clot burden. But the definitive diagnostic procedure is still pulmonary angiography. This invasive study gives a detailed, precise map of the blockages, the webbing, strictures, tapering patterns characteristic of CTEP. Absolutely crucial for surgical planning if that's an option.
Serology blood tests also seem important for underlying systemic conditions.
That's right. Lab data are crucial for screening. Includes an HIV test if indicated. All patients should have autoantibodies checked ANA, Rheumatoid factor, anti-CL70 screening for rheumatologic diseases like scleroderma, which are often linked to pH. Liver function tests, hepatitis serology screen for liver disease, looking for pulmonary hypertension. And methamphetamine use is increasingly recognized as a cause, so screening might be considered in certain contexts. Finally, BNP and NT-proBNP levels are crucial biomarkers. These hormones are released when the heart is stretched, and they correlate strongly with RV dysfunction, how bad the hemodynamics are, and functional status. Plus, they're invaluable for tracking treatment response.
So with all these layers of investigation, what's the ultimate gold standard? The definitive test for diagnosis and accurately assessing severity and the specific hemodynamic profile.
The ultimate gold standard is invasive hemodynamic monitoring with right heart catheterization, or RHC. It's absolutely essential, not just for confirming the pH diagnosis, but for accurately guiding therapy selection. It gives us direct, precise measurements of pressures and cardiac output. The diagnostic criteria require that mean pulmonary artery pressure, mPAP, to be 20 millimilli Hg. Then, we meticulously distinguish between precapillary and postcapillary pH using the pulmonary artery wedge pressure, plus a T, or left ventricular and diastolic pressure, LVEDP. A pulse at 15 millimilli Hg means precapillary, the problems in the arteries before the capillaries, typical of PAH. A pulse P 15 millimilli Hg means postcapillary, suggesting back pressure from the left heart. Okay, so wedge pressure is the key differentiator there. It is. And then we refine it further with pulmonary vascular resistance, PVR. Isolated precapillary pH requires a PVRU 3.0 Wood units, WU, reflecting that high resistance in the arteries themselves. Isolated postcapillary pH has a PVR 3.0 WU. And critically, we increasingly recognize combined pre- and postcapillary pH where you have elevated MP20, high PVR EVO3, and high POP15. It's complex overlap. These precise numbers and classifications are fundamental for accurate subtyping and tailoring treatment, essential for mastery.
This is where the numbers truly tell the precise story, quantitatively. And what about vasoreactivity testing during the RHC? Is that still routinely done?
Vasoreactivity testing is a very specific, important component, but it's mainly reserved for patients with idiopathic or hereditary PAH. It identifies a small but prognostically distinct subgroup. During the RHC, we give short-acting vasodilators, inhaled nitric oxide, or epoprostenol, and watch the hemodynamic response closely. We're looking for a positive response. mPAP drops by 0.10 millimilli Hg to an absolute level, 0.40 millimilli Hg, without cardiac output dropping. These rare responders, fewer than 5% of PAH patients, they have a particularly favorable prognosis and can potentially be treated with high-dose oral calcium channel blockers, a totally different strategy. Identifying these few true responders is crucial because their management and outcomes differ significantly.
Okay, so we've defined pH, explored its complex biology, navigated that intricate diagnostic maze. Now, how do we classify it? What's the big picture framework for understanding the different types, and how does this classification actually guide our approach?
Right. The classification system, particularly the WHO clinical classification, is absolutely essential for organizing our thinking. It was first formulated back in 1998, and it's been refined over the years through World Symposia on pH. The main purpose is twofold. One, to help test new treatments in similar patient groups, and two, crucially, to guide management decisions, allowing for more targeted therapy. Grouping patients with similar underlying issues makes sense for research and treatment. The current system, revised in 2018, recognizes 5 distinct pH categories, or groups. Each has its own characteristics and therapeutic considerations.
Let's start with Group 1, Pulmonary Arterial Hypertension, PAH, which we've already touched on as that distinct severe subtype. What makes this category distinct, and what are its key features again?
Okay, Group 1 PAH. It's fundamentally characterized by that marked pulmonary arterial precapillary remodeling. We discussed the severe structural changes, intimal fibrosis, thick media, arteriolar occlusion, and those classic plexiform lesions, those tangled masses of cells specific to severe PAH. Hemodynamically, it meets those strict criteria. Sustained mPAP, 20 millimilli Hg, PVRU 3.0 WU, and importantly, a normal wedge pressure, pro-PP, or LVEDP, 0.15 millimilli Hg, confirming the problem is before the capillaries. Now, within idiopathic PAH, IPAH, where we don't find specific cause, there's been a fascinating and important shift in understanding. Historically, back in the 80s, the average diagnosis age was around 36.
Young.
Yeah, very young. But contemporary international data now shows the mean age of PAH patients is actually between 54 and 68 years old. This reflects a big rise in awareness and diagnosis in the elderly, challenging old assumptions. Also, while IPH is still seen about 3 times more often than women, men who get it often present with more severe hemodynamics and tend to have a worse prognosis. Suggests potential biological differences or maybe diagnostic delays in men. Nuances like this are key.
That's a powerful example of how understanding changes. Are there specific diseases or conditions commonly associated with PAH within this group 1?
Yes, definitely. Several forms of PAH deserve specific mention under Group 1, each with unique clinical points. A major one is PAH associated with congenital heart disease that involves an intercardiac shunt, a hole between chambers. Recognizing this is critical because, depending on the defect, surgical correction might be possible and lead to a great outcome if done at the right time. It's subclassified into things like Eisenmenger syndrome, where the shunt reverses. Other shunts, coincidental defects, post-op defects. And here's a critical point for the learner aiming for mastery. Surgical repair ideally needs to happen before the pulmonary vascular resistance, PVR, gets stuck above 3.0 WU. If you wait too long, you risk developing irreversible Eisenmenger syndrome. Missing that window is devastating.
Wow, okay, timing is everything there. What else?
Another common association is connective tissue diseases, especially systemic sclerosis-associated PAH. This is particularly challenging, carries a heavy prognosis. Important to distinguish between limited and diffuse scleroderma, as the pH type can differ. PAH and scleroderma is particularly worrisome. Then there's portal pulmonary hypertension, seen in maybe 10% of patients with portal hypertension from liver disease. Often has a high cardiac output state, critical to distinguish it from hepatopulmonary syndrome, which is different. Portopulmonary PH is also a bad sign for outcomes after liver transplant. Finally, HIV-associated PAH. While the exact prevalence isn't perfectly known, it's a significant cause of death in HIV patients, with a particularly poor prognosis, regardless of the HIV stage itself. These specific associations really highlight the need for tailored screening and management.
Moving to group 2, this one seems more intuitively linked to the heart pulmonary hypertension due to left heart disease. What's the core mechanism here?
Indeed. Group 2 clearly links pH to problems starting on the left side of the heart. This includes pH due to left ventricular systolic dysfunction, weak pump, aortic and mitral valve disease, flow obstruction leakage, and heart failure with preserved ejection fraction, HFpEF, stiff, non-relaxing ventricle. The hallmark here is elevated left atrial pressure. This causes a backup of pressure into the pulmonary veins, leading to pulmonary venous hypertension. The left side isn't clearing blood efficiently, so pressure builds upstream into the pulmonary arteries. Even mildly elevated mPA in these patients is linked to worse outcomes, so any degree of pH here matters. And clinically, if you see significant pH with severe mitral stenosis or regurgitation, that's often a clear signal for valve intervention. Fixing the valve can often help the pH significantly.
And can that back pressure actually damage the pulmonary vessels themselves over time?
Yes, absolutely. Chronic pulmonary venous hypertension, if it goes on long enough, can regrettably lead to a reactive pulmonary arterial vasculopathy. In these cases, the PVR itself climbs to O3 Wood units. The vessels start developing their own resistance beyond just the back pressure. You see arterial remodeling, fibrosis, medial thickening, similar to PAH, but also critically, changes in the pulmonary veins, venule sclerosis, and thickening. It becomes this vicious cycle. Left heart problem causes venous congestion, which then triggers secondary remodeling in the arteries and veins, making the pH worse and harder to treat.
So the lungs themselves can also be the primary culprits, leading to PH, that's group 3, and you said it's the second most common cause overall.
Correct. Group 3 covers pH due to chronic lung disease or sleep disorder breathing. Very common scenario. Seen in conditions like COPD, interstitial lung disease, ILD, and mixed patterns like bronchiectasis, cystic fibrosis. Generally, the pH associated with chronic lung disease is usually modest. For instance, maybe 90% of COPD patients have an mPP over 20, but only about 5% have really severe pH, say mPP over 35. The main driver here is chronic hypoxia, low oxygen causing vasoconstriction, and eventually remodeling.
But not always modest.
No, not always. It's vital to recognize a subgroup with severe pH coming from their primary lung disease. These patients are clinically very challenging, poor prognosis. They often show extensive arterial involvement, a very low diffusing capacity, DLCO, on PFTs, indicating bad gas exchange damage and inhibited vasoreactivity. All signs pointing to poor outcomes. Similarly, sleep-disordered breathing syndromes like sleep apnea typically cause mild pH, but it still adds to the cardiovascular burden and needs treatment.
This brings us to group 4, chronic thromboembolic pulmonary hypertension, CTEPH. You mentioned earlier it's often underdiagnosed but potentially curable. What are its unique features again?
Right. Group 4 is CTEP. Develops after chronic thromboembolic obstruction, old clots that didn't dissolve from a pulmonary embolism, but instead organized into fibrotic blockages in the pulmonary arteries. While the incidence after a known PE is maybe 3–7%, here's the surprising fact. About 25% of CTEP patients have no history of a clinical VTE.
A quarter, wow.
Yeah. Suggests you can develop from subclinical clots, maybe tiny ones, or other mechanisms entirely. Underscores why it gets missed. You see both proximal blockages, webs, strictures, and distal vessel remodeling. The key thing is these are organized chronic obstructions, not fresh clots. And for many patients with accessible clots, surgical pulmonary endarterectomy, physically removing these obstructions, can be curative. It's often life-saving surgery.
And after such a dramatic surgery like pulmonary endarterectomy, do all patients fully recover? Or do some still face challenges?
That's a crucial question. While the surgery can be curative for many, about 10–15% of patients will unfortunately develop a disease that looks very much like TAH after the resection.
Oh, really?
Yes, often termed persistent or residual CTEPH. It significantly complicates management, as these patients then need targeted PAH-specific drug therapies. It suggests some underlying vascular predisposition in certain individuals, even after you remove the mechanical blockage.
Finally, Group 5 sounds like the miscellaneous or other category for rarer causes. What sort of things fall into this group?
It is indeed the catch-all. Group 5 includes miscellaneous disorders affecting the pulmonary vasculature, rare or inconsistent causes of PH. For example, sarcoidosis PH here is mainly from granulomatous inflammation directly damaging vessels, though sometimes enlarged lymph nodes can compress vessels too. Sickle cell disease, about 6–10% develop PH due to a mix of factors. Hemolysis, low oxygen, clots, high cardiac output, liver issues, very complex. And globally, schistosomiasis, that parasitic infection, is actually one of the most common causes of PH worldwide. Inflammation from the parasite eggs triggers vascular changes, often alongside liver disease. A huge challenge in Group 5 is that the efficacy of the PAH therapies we'll discuss next is largely unknown in these specific populations. This highlights a massive unmet need, especially for conditions like cysto-associated PH. Big area for future research.
Okay, this is where the story really shifts from, the often grim diagnosis to profound hope and life transformation. How has the treatment landscape for PAH evolved, and what kind of impact has it truly had?
Dramatically, just heroically.
Yeah.
The history here is a testament to scientific progress. Before we had disease-specific therapy, the 1- and 3-year mortality rates for idiopathic PAH were devastatingly high, 68% and 48% respectively.
Terrible odds.
Terrible. Patients faced a grim prognosis, median survival less than 3 years. Today, the landscape is completely revolutionized. We now have 14 FDA-approved medical therapies. Standardized, aggressive treatment strategies, often delivered at specialized pH centers, are the norm. This revolution has fundamentally improved survival rates, now around 91% at 1 year, 69% at 3 years for optimally treated patients. It's a truly remarkable turnaround from what was once considered a rapidly fatal disease, almost a modern medical miracle, really.
That's a truly remarkable turnaround. But beyond just improving survival, what's the new goal for PAH treatment? Has the bar been raised?
Absolutely. The bar has been significantly raised. The goal has shifted from merely delaying death to achieving a low clinical risk profile. This is much more ambitious. It's defined as aiming for a 1-year mortality risk of less than 5%. To achieve this, we're looking for a patient with minimal symptoms, WHO, functional class 1 or 2, but good exercise capacity, say a 6-minute walk distance over 440 meters, and robust heart function, like a cardiac index over 2.5 on RHC.
Okay, so aiming for near normal function.
Exactly. And to get there, most patients will ultimately need 2 or more PAH drugs, often in combination, alongside crucial supportive measures. Risk factor modification, careful diuretic use, supplemental oxygen if needed, and prescribed supervised exercise. It's a holistic, aggressive, highly individualized approach.
So what does this all mean for the learner wanting to master this field? What's the central treatment philosophy now driving decisions?
It means understanding that combination pharmacotherapy is absolutely key. The central philosophy now recognizes the diverse pathogenic pathways at play, even that cancer-like nature we discussed. Therefore, targeting multiple pathobiologic and pathophysiologic events simultaneously is crucial for optimizing treatment. This isn't unique to PAH, right? It's modeled after other complex diseases, HIV, cancer, heart failure, where combination therapy proved transformative. In PAH, it works by attacking the disease from multiple angles, improving outcomes far beyond what single drug therapy could achieve. Early and aggressive combination is often the way to go.
You mentioned 14 FDA-approved drugs. Do they all work differently, or do they kind of converge on a few key mechanisms?
They do work differently, yet they elegantly converge on enhancing or modulating one of three core signaling pathways that are known to be dysregulated in PAH. These are the prostacyclin pathway, the nitric oxide or NO pathway, and the endothelin receptor pathway. The beauty and sometimes the challenge is the variety of delivery methods: oral, inhaled, subcutaneous, continuous IV, offering lots of options to tailor therapy.
Let's break down each pathway and its therapies, starting with that prostacyclin pathway.
All right, 1. Prostanoids, prostacyclin pathway. So in PAH, there's this significant detrimental imbalance. You have reduced levels of the body's own prostacyclin, PGI2, increased thromboxane A2, which constricts vessels and promotes clotting, and decreased prostacyclin synthase, the enzyme that makes prostacyclin. Normally, prostacyclin is a powerhouse. It activates KMP pathways, causing strong vasodilation, inhibiting abnormal cell growth, and stopping platelets from clumping. Basically, it keeps vessels open, flexible, and clear.
And how do we leverage that therapeutically? How do we counteract that imbalance?
We leverage it by giving exogenous prostacyclin, or its analogs, we call these prostanoids, or by using drugs that activate the prostacyclin receptor, mimicking its action. Epoprostenol, given as a continuous IV infusion, was the pioneer. Landmark studies showed it dramatically improved quality of life, MPA, PVR, 6-minute walk distance, and critically, mortality in severe PAH. Then came treprostinil. Longer half-life allows for subcutaneous, inhaled, or even oral administration. Also shown to improve hemodynamics, symptoms, exercise capacity, survival. Inhaled iloprost and inhaled treprostinil offer targeted benefits right to the lungs, often fewer systemic side effects, no catheter risks. And a fascinating oral option is selexipag. It's not prostanoid itself, but it binds the IP receptor tightly, mimicking prostacyclin. A huge trial shows selexipag added to background therapy cut the risk of hospitalization or disease progression by 43%. Really highlights the power of effective oral options in this pathway.
Okay, moving to the second pillar, the endothelin pathway. What's endothelin's role in driving PAH?
2. Endothelin receptor antagonists, ERAs, endothelin pathway. Endothelin 1, or ET1, is a critical player in PH pathology. It's one of the most potent natural vasoconstrictors we know of, and it's a strong, vascular, smooth muscle mitogen, meaning it narrows vessels and makes the muscle cells in the walls grow abnormally. In PAH, ET1 levels are often elevated, and they correlate positively with how bad the PVR and mPAP are, and inversely with cardiac output clearly showing its detrimental effect. ET1 acts through two main receptors, ETA and ETB. ETA mainly drives the bad stuff, vasoconstriction, cell proliferation. ETB is a bit more complex, involved in clearing ET1 and some vasodilation, but overall unchecked ET1 activity is highly harmful in PAH.
So the ERAs specifically block these harmful effects of endothelin.
Exactly. 3 ERAs are approved in the U.S. Bosentan and macitentan are non-selective, blocking both ETA and ETB. Ambrisentan is selective, primarily blocking the ETA receptor. Clinical trials were key here. Studies like BREATHE-1 for bosentan, ARES-1 for ambrisentan consistently showed the improved hemodynamics, exercise capacity, and delayed clinical worsening. The SERAPHIN trial with macitentan was particularly significant. Huge trial. Showed a remarkable 45% reduction in the risk of PAH-related clinical worsening death. Progression, even in patients already on other PAH drugs, really solidified the role of ERAs in modern treatment.
And the third major pathway, nitric oxide. How do we therapeutically modulate that system?
3. Nitric oxide pathway effectors. Okay, nitric oxide, NO, it's a vital gaseous molecule produced in the vessel lining. NO activates an enzyme called soluble guanylyl cyclase, GC, which then produces cGMP. cGMP is the key second messenger here. It induces vasodilation, relaxing the vessels, and inhibits platelet activation, preventing clots. Now, the body also has enzymes called phosphodiesterase type 5, PD5, which break down cGMP. They're highly expressed in the lungs. So PDE5 inhibitors like sildenafil and tadalafil work simply by stopping this breakdown. They maximize the NOA-dependent vasodilation and anti-proliferative effects, boosts the body's natural system, improves hemodynamics, 6-minute walk.
Right, the same drugs used elsewhere.
Exactly, same drug classes for erectile dysfunction, just acting on the same pathway in the lungs. Beyond PDE5 inhibitors, there's riociguat, and offers a unique approach. It directly stimulates SGC, independent of nitric oxide, which is important because NO availability might be low in PAH. Riociguat also stabilizes the NO-HGC interaction, further boosting cGMP production.
So a dual mechanism there.
Yes, a dual mechanism ensuring robust cGMP levels. Riociguat has shown significant improvements in exercise capacity, hemodynamics, functional class, time to worsening in PAH. And crucially, uniquely, it's the only approved drug therapy for CTEP patients who aren't candidates for surgery or for whom surgery wasn't effective. Makes risegwand a vital non-surgical option for that specific group.
That's a lot of powerful options across these three pathways. So how do clinicians put it all together? How do they create a modern, individualized treatment strategy for someone with PAH?
Right, the modern strategy is highly individualized, but it generally follows a risk-stratified approach, absolutely key for optimizing outcomes. For newly diagnosed treatment-naive patients, that vasoreactivity testing during RHC is a crucial first step. If they're a positive responder, that rare 5% group, they're typically treated with high-dose oral calcium channel blockers and generally have a much better prognosis. For the vast majority who are not vasoreactive, treatment selection is driven by their clinical risk profile, low, intermediate, or high risk. High-risk patients, those presenting really sick, advanced heart failure, syncope, they need aggressive upfront combination drug therapy. Critically, this usually includes intravenous prostacyclin therapy, the most potent class, often given with other oral agents right away.
Okay, start strong for high risk.
Exactly. For low or intermediate risk patients, the standard approach now is to initiate them on combination oral therapy from the outset, typically an ERA plus a PDE5 inhibitor. Attack multiple pathways simultaneously from day one. Then, if a patient deteriorates or just fails to improve sufficiently to reach that low-risk status, subsequent add-on therapy, often triple therapy incorporating a drug from the third pathway, like an oral prostacyclin pathway agent, is considered. The goal is always to achieve and maintain that low clinical risk profile. This idea of upfront combination therapy, starting two drugs at once for many patients, seems like a significant departure from older approaches, right? Was that a big deal when that data came out? Oh, it was indeed a landmark shift in practice. The AMBITION trial was pivotal. It randomized over 500 treatment-naive PAH patients to either upfront combo therapy, ampersandtan plus tadalafil, versus monotherapy. The results were compelling. Upfront combo led to a remarkable 50% lower risk of clinical worsening, mainly by delaying the first hospitalization, and crucially, with no increase in side effects.
Wow, 50% lower risk.
Yes, it unequivocally showed the clear benefit of starting aggressive treatment early and hitting multiple pathways simultaneously. Subsequent registry data suggest this benefit likely extends to other EAPD5I combos too, underscores the power of early, aggressive combination therapy, and of course, for the most severe cases, refractory even to maximal medical therapy, procedural options like lung transplantation remain the ultimate, albeit last resort, option.
Okay, despite all these incredible advances, the revolutionary treatments we've discussed, it still sounds like there are significant challenges. There's still a long way to go towards truly conquering this disease complex. What are the lingering unmet needs in the field of PH?
You're absolutely right. While quality of life and survival have improved substantially, no question, patient mortality and limitations in quality of life remain at, frankly, unacceptable levels. There are critical unmet needs. A fundamental one is still the persistent challenge of improving awareness among clinicians, among patients to facilitate more timely diagnoses. We talked about those delays. They directly impact therapy response and survival. Getting that diagnosis sooner remains a huge goal.
Right, awareness and early detection.
Exactly. Another key challenge is ensuring all patients have equitable access to specialized PH centers for that state-of-the-art multidisciplinary care. The expertise, the full diagnostic toolkit, the diverse therapies, they just aren't available everywhere. Furthermore, we still only have therapies targeting those three main pathways for PAH. And while they're effective, they don't sufficiently reverse the profound vascular remodeling to provide truly definitive, curative, or long-term benefits beyond 10 years for all patients. This points to a pressing need for therapies that don't just dilate vessels or slow growth, but actually repair the existing damage, restore normal vessel structure. The role of current drugs in early-stage disease is also largely unknown. Current indications are mostly about improving exercise or delaying worsening, not prevention or early reversal.
So if the focus is shifting beyond just vasodilation, what's on the research horizon? Where are the next breakthroughs expected? What insights are guiding that future research?
The research horizon is incredibly dynamic. The focus is indeed shifting towards treatments that specifically target fibrosis, inflammation, and those dysregulated metabolic changes in the pulmonary vascular cells, moving beyond just vasodilation. This is critical because, as we said, it's a proliferative remodeling disorder. This raises that important question we're actively pursuing. Can insights from cancer biology, the role of PDK, and EDD9 truly translate into novel therapies? Can we develop compounds that specifically target these underlying cellular derangements, essentially reversing the cancer-like proliferation, metabolic shifts, scarring in the pulmonary arteries? That cross-pollination between fields holds immense promise for truly disease-modifying therapy.
So that sounds like a major shift in therapeutic targets.
It is, and crucially, a massive unmet need lies in developing disease-specific treatments for those large vulnerable populations with PH due to left heart disease, group 2, or chronic lung disease, group 3. These groups represent the most common causes of PH worldwide, yet our therapeutic options for them are severely limited compared to group 1 PAH. Developing drugs tailored for these groups represents a massive unmet need and a huge area for future research. We desperately need to explore new mechanisms, broaden our arsenal beyond the current 3 pathways to tackle the full spectrum of PH.
It sounds like we've made incredible strides, truly rewriting the prognosis for many, but the journey towards true mastery and definitive cures for all forms of PH is still very much ongoing. Exciting frontiers ahead, though. Hashtag outro. Okay, that was a truly deep dive into pulmonary hypertension. We've covered a lot of ground from the very definition and those subtle, often missed signs, through the intricate cellular and molecular pathobiology underpinning it all, to the systematic, multi-layered diagnostic process, and finally, the revolutionary risk-stratified treatment strategies that are genuinely transforming patient outcomes for many.
Yeah, our goal today was really to provide you with that elite level understanding, drawing heavily on Chapter 283, covering every key topic and concept in meticulous detail. By breaking down the complexities of PAH and the other PH subtypes, exploring the nuances of diagnosis from echo to RHC, and detailing the pharmacologic pathways and modern treatment algorithms, you should now have a comprehensive, nuanced framework for this challenging and evolving field, essential for true mastery.
And for you, our learner, we hope this deep dive has given you not just information, but true insight, the kind that informs critical thinking and clinical practice. You now understand why just a small shift in a diagnostic number can mean years of life for a patient, why a disease seemingly in the lungs is ultimately a systemic challenge for the entire body, and how these targeted molecular therapies are quite literally rewriting the prognosis.
So, what does this all mean for the future, for patient care, for the ongoing quest? Given these rapid advancements, particularly recognizing those cancer-like pathways in PAH and the continued push for earlier, more precise diagnosis, consider this provocative thought to take away. How might genetic screening and truly personalized medicine strategies, leveraging these deep pathobiological insights we've discussed, not just treat, but potentially prevent or even reverse the earliest stages of pulmonary hypertension in the next decade? Could we actually anticipate, intercept, and maybe even cure this disease before it ever truly takes hold?
A fascinating thought to mull over and a powerful vision for the future. Thank you for joining us on the deep dive. We hope this has equipped you with knowledge that inspires further curiosity and deeper exploration into this vital area of medicine.